So I'm just going to talk about our project that is a collaborative project with Western Health, Royal Melbourne, Royal Women's and BRECAN, as well as Medicare Locals. And that's just listing our project team. So what we aim to do as part of our project was to develop and implement and evaluate a comprehensive end of treatment survivorship program for these patients that we've all been talking about who have finished their treatment and they're going into what happens after that 12-month checkup time and from there on after. And as part of the evaluations or the assessments that we've been doing, we do see that they've got a lot of unmet needs. They've got different needs to what they had at diagnosis. So, you know, we're just saying, oh, everything's finished, off you go, and you'll be fine now, back to your normal life. Life's different, it's not the same. They've got issues after treatment, like a lot of women, as we said earlier, is hormone therapies affecting their sexuality, their well-being. It's an opportunity to evaluate them at that point of time, and also to make sure that they've got a driven sort of follow-up process, that they know what their follow-up care is going to be and look like for the rest of their lives. And also we're looking at where we've got women coming into clinic and they might have a clinic appointment one day with the surgeon and a week later they might be coming to see the oncologist. There's no collaboration amongst all that. And we do work within a multidisciplinary clinic, so we have our surgeons and oncologists all working side by side in clinic with the breast care nurses. So we have that opportunity to design a follow-up plan that actually includes input from all the team players. So we set up to have a nurse-led, well actually at the beginning when they're diagnosed and we have a multidisciplinary discussion about that patient's treatment and care, we're determining that that patient's an early breast cancer and would be suitable for a survivorship or a shared care follow-up, and that's at the very beginning. And then around about the 11-month mark, we're looking at 10 to 11 months post their diagnosis or first surgery, is when we're going to be looking at they're due to come back for their annual checkup in clinic. We do organise another multidisciplinary discussion to determine what their follow-up care would be. So that gives us input from all the team players about that patient. We have a case discussion and determine what that follow-up would be for that patient. Then they come and see the breast care nurse at a breast care nurse consultation, which takes about an hour, where we evaluate, we do supportive care screening, health and wellbeing screening, gives them an opportunity to discuss what their follow-up care should be and how they can be involved in that as well, and encouraging them to be participants as well in their follow-up care and their health and wellbeing, as someone's mentioned earlier about exercise programs and all that. I'm not going to go into all that, I'm just giving an overview really. We also devised a survivorship package to build a follow-up care plan which shows a treatment summary, diagnosis and treatment summary, health and wellbeing issues and their follow-up plan, and that goes to the patient, to the GP and to the patient's medical record. Also, the target group, as I said, were early breast cancer survivors or patients with DCIS between the 6 to 12 month post-diagnosis. And that just shows you what key project components were in enabling GP engagement, consumer engagement, breast care nurse consultation and developing a follow-up care plan. And in the initial stages of the project, we had a lot of meetings and engagement with GP groups, focus groups with consumers to get everybody's input about what that should look like, when the consultation should occur, what the care plan should look like, what the screening tool should be. And there's if you can see, it's not very clear, but that's a follow-up care plan that we utilise with all the treatment summary. You'll see on this actually, in reality, works over a few pages by the time we've put all the follow-up care in as well, which is the little box down the bottom on the other side there. But that just gives you an idea of what it looks like. We also, when we developed this, was so that it did fit with the GP model for their health and wellbeing management plans as well, and they can utilise the information on this as part of their care plans. There's another page where it gets signed off. Once it's all agreed upon by everybody, the surgeon will sign off, as will the breast care nurse who's had the nurse consultation with them. And the last page, there's a recommended follow-up frequency, which is really put there for the GPs, so that where the GPs are actually following up with the patient, they've got some guidelines that we've taken from, as adopted from the MBOCC follow-up plan in 2010. So at Western, we devised the risk stratification for these early breast cancer patients so that we could stratify them into low, medium or high risk, so that when we're doing the multidisciplinary case discussion about what that follow-up would be, we've already fit them into that category, and then everybody either agrees or doesn't agree with it. Sometimes it gets altered around according to the patient needs and with discussion with the specialists. And our basic guidelines for developing that risk stratification makes it easier for the breast care nurses when we're doing the preparation for the multidisciplinary meeting as to where the patient should fit. That gives us a bit of a guideline. So key enablers for the project was developing resources and processes. There was a fair bit of time to put together what should be in the resource packs and information that we're giving to patients, what information we should be giving to GPs, and what processes we should be doing across the whole project. We had a lot of consultation, as I said, with GPs and women, and with the breast service clinicians across the 3 sites, including breast care nurses, surgeons, the whole multidisciplinary team. And when we set up the nurse-led clinic, we've set it up as a VAX clinic so that we're tapping into some funding and able to run it as purely as a nurse-led clinic that is purely not for any medical assessment. It's purely for supportive care, screening and health and wellbeing and follow-up discussion. And then about a month to 2 months later, after they've seen the breast care nurse, they come to see the surgeon or the specialist in clinic, whichever one it is that they're seeing, after they've had their mammograms and ultrasounds and whatever other tests they need to have. And they have that follow-up care plan with them at the clinic appointment, so that the specialist that's seeing them can look at when their follow-up and try and follow that guide as to when they should be coming back, so that everyone's on the same page. That's the idea. We also had extensive support from BRECAN, who did all our valuation and a lot of input, and we've developed some really good follow-up models with them. And as Lee said earlier, that we have quite a lot of women from COL backgrounds in our area, so we've developed with our nurse-led clinic processes, we do it with interpreter. So to us, we're always seeing patients with interpreters, so it's no different. The only thing is the hard bit is having any written information in other languages. And with the help of BRECAN, we're working towards some, outcomes with that. In the GP engagement has been a really big part of this whole project, in that we're trying to develop communication pathways between the clinic and the GPs. As a result, we've run a lot of focus groups. We've run some education sessions with GPs where they can get the CPD points. We give them access to rapid referrals straight back to the clinic via the breast care nurse, so they've got a phone number they can directly get onto us to get a patient back in if they have any concerns, and really working on developing those communication pathways. Also with consumer engagement, as I said, and looking at funding for continuing the model of care. With the pilot project, we had extra hours for implementing the program and having extra hours for the breast care nurses. And the aim of when we started the project was that we would have it as a sustainable model that we would continue and embed into practice, which we have worked towards without those extra hours once at the end of the project. So that's where we're sort of working and still doing this after the end of the project, which was at June last year. There's just some of our statistics. This is across the 3 sites of the numbers of total patients that were offered nurse-led clinic and follow-up shared care. We only had 5 that cancelled. We had 8 failed to attend. For some that couldn't come in, we did phone consultations and had found that we had the same as good an outcome in terms of discussion and follow-up. Some of the patients that came in for discussion was quite interesting. They would come in alone or they'd come in with their husbands or partners, and a lot of it would be talking about sexuality and their well-being, how they're feeling about things at this point in time, especially if they have a lot of side effects from treatment. So it's been quite beneficial from that point of view to be able to sit down with the patient who we've known right from the time of diagnosis. I'm just going to flick through some of these slides, but we had some interesting feedback from GPs. Consumer surveys were sent out. Where we've got internet and GP information, we expect it over time to start to see those sort of levels start to increase. And 83% that did not have any more issues, and 83% that they were did not think that anything could be done better. So there's about 17% that thought otherwise. So we're aiming to reduce numbers in clinics, have more patients going back to see their GPs, especially beneficial for those who don't speak English, with a lot of the Vietnamese patients going back to their own doctors seen to be quite beneficial. To improve the model of care and making sure that they're integrating well back into the community with links back to us at all times. And the other outcome that we've had is development of an e-tool, which we've left some brochures out there for everyone to take some home, and this has been developed at BRECAN, and also with e-referrals to directly refer patients back to BRECAN for support as well. That's been really beneficial as part of our process at the time. Future direction is to embed this into practice. The difficulty has probably been reducing hours and still trying to do it. There you go. I've finished.